Okay, welcome. Welcome to the American Journal of Bioethics latest panel discussion. Today we will be talking about vaccine mandates. I'm David Magnus, editor-in-chief of the American Journal of Bioethics. As the latest COVID-19 surge continues to rage throughout the United States, low vaccination rates in parts of the US have contributed to overrun ICUs. Many attempts have been made to increase vaccination rates, including lotteries, public health messages, and the surge itself has had at least some impact on vaccination rates. One strategy to increase vaccination rates is through mandates. Many and possibly most healthcare workers are now required to be vaccinated, and I put required in quotes. Many and perhaps most colleges and universities have likewise required vaccinations for students and many for faculty and staff as well. At the same time that some states, such as California, have mandated vaccination for healthcare workers and others, other states have resisted mandates. For this panel, we will be discussing the ethics and social acceptability and importance of vaccine mandates. Who should mandate them? What kind of exceptions should exist? What sorts of penalties are appropriate? Today, our panelists include Arthur Caplan, PhD, who is the Doctors William and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at NYU School of Medicine. During the COVID pandemic, he has created a working group on coronavirus vaccine challenge studies, developed an ethical framework for distributing drugs and vaccines for J&J, and helped develop rationing policies for NYU Langone Health and many other health systems. He is a member of the WHO Advisory Committee on COVID-19 Ethics and Experimental Drugs Vaccines, and he helps set policy for Western IRB, WCG for research studies. He's an advisor to Moderna and serves on the NCAA COVID-19 Medical Advisory Group. Seema Mohapatra, JD, is currently the Murray Visiting Professor of Law at SMU Dedman School of Law. Prior to visiting at SMU, Professor Mohapatra was a tenured professor at Indiana University Robert McKinney School of Law, where she twice earned the Dean's Fellow title and award for outstanding scholarship. Seema Mohapatra's research interests include the intersection of biosciences and the law, assisted reproduction and surrogacy, international family and health law, healthcare equity, and informed consent. Kevin Schulman, MD, MBA, is Professor of Medicine, Clinical Excellence Research Center, and Associate Chair of the Department of Medicine at Stanford University School of Medicine, and by courtesy, Professor of Operations, Information, and Technology at Stanford's Graduate School of Business. He's the founding faculty director of the Master of Science in Clinical Informatics Management at Stanford, and he's made important contributions to the use of behavioral economics to address vaccine hesitancy. Matt Wynia, MD, MPH, is the director of the University of Colorado's Center for Bioethics and Humanities, trained in internal medicine, infectious disease, public health, and health services research. From 1997 to 2015, Dr. Wynia was a leader in several program areas at the AMA, including the AMA Institute for Ethics, the Center for Patient Safety, the Commission to End Healthcare Disparities, and the Improving Health Outcomes section on patient and physician engagement. Dr. Wynia has led projects related to ethics and professionalism in healthcare, and with the National Academies, the Joint Commission, professional associations, and multiple government agencies on topics from public health to disaster ethics and many more. Okay, so first question, and I'm going to start with Matt. Let's start with mandates for healthcare workers. Owing to the special obligations that healthcare workers have towards patients, healthcare workers have been among the very first to be required to have proof of vaccination, in some cases as a condition of employment. Critics have expressed concern that mandates may undermine trust between healthcare workers and the institutions that employ them, and that alternatives exist to avoid occupational transmission. I think everyone agrees this is a step that should not be taken lightly. What would justify requiring healthcare workers to be vaccinated rather than to keep it voluntary? What are the key factors, and are we at that point today? So let's start with that question.
9 months after vaccines against COVID-19.
Don't know what that was from.
That was not me.
I don't know what that was. So Matt, why don't you go ahead?
Yeah, so the things that I think about in terms of when is it appropriate to pull the mandate card, if you will, is what's the level of risk in the community at the moment, and have we given enough time to the voluntary strategies to know that they are or are not going to work. In the long run, most vaccine preventable diseases require a mandate if you need to achieve community-wide immunity in order to keep it under control over the long term. It just, the way history has played out over and over again. In the absence of a mandate, not enough people will voluntarily get inoculated. And as a consequence, when the disease starts to go away, even fewer people will be inoculated, and you'll have a resurgence. And we've seen this with measles, we've seen it with rubella, we've seen it with diphtheria, we saw it with smallpox. And so if you have a highly effective vaccine, as we do for COVID today, you're almost certainly eventually going to need a mandate. So I think we're there. I think we were there as soon as we had a highly effective vaccine, because the risk level for the community is so extremely high right now.
Okay, thanks. So high risk, an effective vaccine, and mandates necessary to be able to do this. Let's go to Seema. Your thoughts on whether we're there now, and what are the factors in deciding when it's time to have mandates?
Yeah, I think this is a really difficult question. And I think that, in terms of thinking about whether we're there, obviously right now we've seen there has been a reluctance among certain healthcare workers to take the vaccine, and they're and when you look at the demographic data in terms of who they are, it's not necessarily physicians. We have a lot of, other types of healthcare workers, whether it's nurses or medical assistants and non-physicians that are working in the hospital, that are more likely to not choose to take a vaccination. And I think we need to be at least cognizant of the fact of, in terms of public health ethics, we want to only use mandates when we have, as Matt mentioned, already tried other means. And so, there is a question about whether, we are going to, are there more carrots that can be used, or, is it time to use sticks, much the way as Delta Airlines has, and then has seen a uptick in vaccinations after they said, if you do not get vaccinated, you will have to pay part of your insurance premium and have more regular testing. And so, I think there are other ways to think about it. My concern in terms of, and you mentioned it in your question about forcing people to get vaccinated, is that for certain groups, this is going to increase this distrust, and this distrust is going to go beyond this pandemic. And, when we're talking about also not just demographic groups of who, which types of healthcare workers, there's also a concern about which racial demographic groups are going to be the ones that might be the unvaccinated employees that are either going to get fired or, have negative consequences to their employment. And so, I am kind of wondering whether having more periodic testing, providing PPE, and encouraging vaccination, and then moving people to non-patient facing jobs if they don't have, if they're not vaccinated, might be a more equitable kind of strategy. That said, I think this is a real problem when we are talking about the fact that we have vulnerable populations in the hospital. We have a mandate from healthcare workers, basically, to do no harm. And so if they are the reason that the disease is spreading, that might be a problem. And if we have healthcare workers that are not able to come in because they are sick from COVID-19, we also have an issue where we're already seeing ICU beds full in lots of places. So this is, I'm not taking this lightly in terms of the fact that, and I'm not anti-mandate. I just think that we really need to think about these carefully and thoughtfully, and think if there are alternative means, because we have seen we need to have some kind of trust in our employers. And we saw in the beginning of the pandemic that healthcare workers, particularly non-physician healthcare workers, were not even given PPE by their employers, and not even, had to provide that on their own, and were not given protection. So yes, there was, banging on the pots and celebration, but they were facing risk. And so in that context, I think we should think about how are we going to regain the trust from employers, and instead of possibly having another barrier.
Okay, thanks. Art? You're on mute.
My better state mute. I'll be a little provocative and say, I don't agree that we should be trying persuasion and incentives before mandates. I think morally, this epidemic, as soon as the variant appeared, was posing such grave risk that the idea that we have to educate and persuade people to make a choice is not, in my view, the proper public health response. Remember, most of us are focused in, because we all work in healthcare, on the burden in the ICU and nurse burnout, and as Seema was saying, histories of mistrust because of inadequate supplies pre-vaccine. In New York City, near where I am in Connecticut, the Rikers prison is out of control because there are no guards. Prisoners are taking people to court. There have been 10 suicides in the past 3 months because the gangs are out of control and they can't control the place, and it's all due to absence due to COVID. Pediatric diabetes on the rise because pregnant women haven't been vaccinated properly, and there's a suspicion that that's causing it. Most first responders in many state police, just I'll use Massachusetts, one I know about, are saying, well, I've been exposed or I might have had it, so I don't need a shot. And whether or not they were exposed isn't clear. And whether or not the level of their exposure would give them enough immunity isn't clearly the best defense. So 3 points. When you have a rapidly spreading strain that really looks like it's out of control, it's reverberating throughout our society, and obviously it has implications for overseas too, which we'll get to later, but let's just talk about here. It is clear that education is slow. I believe, sorry, Kevin, that the incentive programs are weak in terms of changing behavior that we try. We don't have really time to test them anyway. So if you have a society that's shutting down, people are screaming about schools, prisons can't staff, first responders are out for ambulance and EMT because they can't get there, ICU's overwhelmed. Why would we be slowly trying to persuade people that it might be a good idea? I think mandates should go across the board, and I think we're way behind.
Okay. Kevin, I'm going to just amplify the question, since you've published on how vaccination rates can be improved through behavioral economics approaches to recruitment and more concerted marketing. Do you think those approaches should be attempted prior to implementation of mandates?
Yeah, so thanks, David. Thanks for including me. And yeah, I want to pick up for where Art left off, and just go back to the turn of the year when we published our first article, and the issue at the time was, how do we think about a communication strategy for the vaccine? And if this was Apple, and Apple was going to launch a new product, they would have had focus groups out in the field for 2 years to figure out how they're going to tailor messages to different segments of the population. Now, we didn't do any of that, right? We came out, we have an amazing spokesperson, and in terms of Tony Fauci, but we knew in November that half the country wasn't listening to them, and we never reached out to them. And so that's gotten exacerbated till now. So I would say, first off, I think in terms of the question, I think healthcare workers should have a mandate. They're the ones that's the easiest. And we did some work last summer in North Carolina. 50% of nursing home workers are vaccinated. So here we are with the most vulnerable people, the people that have succumbed the most in this pandemic, and the people bringing them their lunch are putting them at high risk. So that's not tolerable. But also in terms of getting the rest of the population on board, if you can point to, look, the healthcare workers aren't doing it. We have a responsibility to bring everybody else forward. Now, I think having mandates and having this roll out, I don't mind the employer mandate either, but it doesn't let us off the hook in terms of doing a better job with our communication strategies at the same time. And we still have to sell this. We don't want to have riots in the streets. We want to have public health. We want to have people begin to line up and get the vaccine. And it's a very focused group of people now that we're looking at, in terms of the tail of the distribution. Some of those people, believe it or not, still have yet to make up, to do the shopping decision whether or not to get the vaccine. And we've written about that and how to message those folks. And then there's the diehards at the bottom that we're going to have a really hard time reaching, even with a mandate. They're going to come in with a religious exemption or something else we're going to have to adjudicate. So, I don't think this is a total panacea, but I think it has to be a communication strategy very focused on the specific populations we're trying to address. And the healthcare worker mandate to me is a no-brainer.
David, can I jump in with just, I want
Yes.
to go back to something Seema said, because the issue of mistrust and equity is really important. And there are ways in which a mandate might actually help in those regards. So I'm not, I don't want to go too strongly at this, but I will say, number one, when there's a mandate that comes down from on high, the institution is somewhat protected, because the institution can say, look, we have to do this. It's the feds, it's the state, right, telling us to do this. We've seen this over and over again with local health departments, where if you talk, individually with the leader of a local health department in an area where there's a lot of controversy over masking, they will say, please give me a statewide mask mandate. It's the only way I can do this. So, number one, there may be some insulation effect by having mandates that are more across the board. And number two, I think in terms of trust, you also have to think about the people in the healthcare organization who feel unsafe as workers working next to people who are unvaccinated. And so it's not just, that you have to build the trust of the unvaccinated. We have to rebuild the trust of the vaccinated as well. And that's the majority, actually, who are vaccinated and scared to go to work because they fear that 30 or 40% of their colleagues haven't made up their mind yet and are thereby putting everyone else at risk, especially if you're someone with, young children at home who can't get the vaccine yet, or who have caretaking responsibilities for, people you really love who are immune compromised, and you're fearful of getting an infection and bringing it home, even if you end up being, unaffected personally, getting no symptoms, you can still transmit it to someone else. So I think we've got a large cadre of healthcare workers who will feel more safe when there is a uniform mandate. And just anecdote, but there are within Colorado some hospitals with and others without right now, or that have been less stringent on their implementation of the mandate. And we're seeing people making applications to move to our system because they want to be in a system that has a strong mandate.
So let me build on some of the equity concerns that have been expressed in some of this debate. A lot of times when people talk about healthcare workers, what they have in mind are physicians and maybe nurses, but actually there's a lot of other lower income workers who work in healthcare systems, like food services workers, environmental services workers, such as janitors. And interestingly, at a lot of the hospitals, including ours, what we see is those are the groups that have had by far the highest rates of COVID and often have the lowest rates of vaccination. They're often poor people and people of color. And for some of those people, actually being able to get vaccinated can be hard and, in fact, a hardship. Some of them work more than one job. I've been really impressed that I keep running into people who work at our institution in their second jobs. You tell me, oh, I also, I deliver a DoorDash, but I also work at Stanford cafeteria and so on. And for those people, a vaccine that might put them out of work for a day or two could mean real lost wages because of those symptoms. How should we address that and make sure to ensure that the vaccine requirements actually increase equity rather than decrease it, that it doesn't wind up creating problems where people have to choose between a vaccine or feeding their children that day, or does this even raise questions about the mandate? Okay, Art, go for
just
it.
a couple of comments there. So one, it's a stark reminder, particularly when we talk about international issues and distribution of vaccines, you need an infrastructure that's amazing to vaccinate an entire population. Remember, we started with vaccines that were being given out at health centers, then we expanded, I'm going to say, to stadiums and civic centers in many places. Still was a pain in the neck. Then we tried to put things into locales in poor neighborhoods, and they were getting overrun by rich people who were driving over there, whereas the poor person, as you were saying, David, had to go to work and couldn't take the time. So a reminder, you must have delivery of vaccine to the person almost to really get this done. house by house, apartment by apartment. That's the lesson, and I've been working on this for many years now with polio internationally. You want to vaccinate the world, you bring it to the person. You don't tell the person to go find the vaccine. You're in the village, you're repeatedly in the village. And we needed something like that to do, a thorough rollout here. And we're slowly getting better, I would say. Also adjustments to time off, so you don't have to bite into your sick time to go. That becomes very important for a lot of people. And then I like the incentives that some companies, Uber and some others, did, where they said, we'll give you a free ride, just go get the darn thing, and we'll take you there, and that sort of stuff. I think that kind of approach could be helpful too. But just to summarize, it isn't just a matter of supply when we think about who's getting vaccinated. It's infrastructure for distribution.
But also, what about the issue of people who have financial hardships because of the fact that they might actually have to lose time, which would be lost
wages? No, I would absolutely compensate lost wages, give them paid leave to recover from any side effect. That, to me, that's like no brainer.
Okay.
Yeah, I would agree that it kind of goes hand in hand, that if you are going to have a mandate, for sure, the employer needs to provide the supports. And so hourly workers that, not necessarily usually have paid leave, that should be an additional kind of leave that they have. And because people have, different kinds of symptoms with these vaccines and different, amount of days, it should be a generous policy that could also go far in building trust. A lot of people that haven't gotten vaccines that are not, politically making kind of a statement, it's because in terms of their needs, they have a lot of things going on, and a vaccine is just one other thing on a list. And when you're trying to pay the bills and make sure you have, childcare and all of these things, we need to make sure that we provide these kinds of support. So I agree with Art that one of the ways to do that is making sure that the vaccine is where you are already, whether that's home, especially for people that, are not necessarily working, that are, people with disabilities, or people that can't go to a facility, but also to come to work and have the vaccine there. For healthcare workers, mostly that is available. However, I think the thought of having a couple of days where they can't work, and when you add it for 2 vaccines, that is a real financial detriment to some people. So I think definitely employers need to provide that, and that should be kind of standard.
Yeah, the scariest thing about the pandemic, from a rounding perspective, was a realization, last spring, that the food workers were going to bring the whole house down. So if you think about what a food worker does during the day and how many people they touch, it was unbelievable. So, so I think, it's not just the doctors and nurses. We have a lot of people that have different jobs around the hospital. That being said, it's a leadership issue to go out and say, what is it that's going to make it make it attractive and make it available to folk, and across these different stratum within our employment base. And we at Stanford, we started doing some surveys over last spring, by the summer, to try and understand who was vaccinated, what the issues might be. But we're still grappling with the leadership issue. It's not like across healthcare across the country, it's not like people running health systems are running commercials. They're running their commercials for the radiology center, the orthopedic center, but they're not running commercials for public health. And so if in fact this was the thing that we were going to do as an organization, rather than get our elective surgeries back up and running, was to make sure we're safe and vaccinated, I think that would put some more focus on what do we do to pick up the pieces when the food worker gets sick and needs childcare. I think we've had some of those things in place, but they've been slow.
I think Kevin's absolutely right. It is a leadership issue. And Seema may want to say more about this. We worked all of last year trying to get the Occupational Safety and Health Administration to issue emergency temporary standards for workforce safety during COVID. And under the prior administration, that was not going to happen. So there's no little irony that it is an emergency temporary standard from OSHA that will probably be the implementation mechanism for this coming mandate. And what that means is OSHA can write rules that require people get paid time off in order to get the vaccine, and paid time off if they need to recover from side effects. So this can be built in, these protections for vulnerable workers and people who are hourly and so on can actually be built in to the ETS that OSHA is anticipated to write. And I hope and expect that they will be.
So even if we do get to the point where vaccination is required in healthcare workers as well as others, religious exemptions are required for employer-based mandates legally, unless such exemptions create a quote unquote undue hardship for the employer. Do you agree that there should be religious exemptions for any employment-based mandates, or is the undue hardship requirement met by concerns for health and safety of the workforce? And I'm going to start with our lawyer in the group, Seema, on this question.
Yeah, thank you. And I will say that my answer to this question has been informed by the work of Dorit Rice and Ross Silverman, so I'll give them acknowledgement on this. But so in terms of the legally, we can critique whether we should be able to have religious exemptions, but we can accept at this point that they are required. But as Dorit Rice has talked about and written about a lot, and she critiques that these are kind of really easy to game and hard to police. And so the question about whether every employer should actually have to meet these religious exemptions is a key one. And there's a good case to be made that for certain employers in certain situations, it's not appropriate to actually grant these kinds of religious exemptions. And so healthcare facilities, nursing home facilities, daycare kinds of settings, whether it's adult or child daycare settings, prisons and jails, those all might be, shelters for the unhoused, those all might be places where if we are going to have all employees or all people required to be vaccinated, that it might not be appropriate to have a religious exemption, and so in terms of thinking, about other people, we might be thinking also about any kind of first responders, any kind of jobs that you cannot do like from a computer remotely, and that, PPE may not be as effective. You can't distance or mask in these kinds of situations, like if you're a police officer. And so those might be some certain things to think about in terms of situations where we might not grant these kinds of exemptions, and that it wouldn't be realistic to have somebody working in those jobs without a vaccination for safety reasons.
Okay.
And okay, so go ahead.
No, that's great. Any other thoughts you have? I didn't mean to interrupt.
Oh, no. I mean, I was gonna, just talk about the fact that, when we're thinking about, I guess, carrots and sticks and some of these behavioral kinds of strategies, I think that there are other strategies to think about, like making sure that those that do have these kinds of exemptions have kind of onerous testing requirements, are not able to necessarily be in person unless they have, submitted their results, I think that having some of these kind of hard like sticks involved might help encourage people to get vaccinated, and then some of these religious exemptions might disappear. And we can't really question, whether those religious exemptions are sincere or not.
Art?
Well, I understand that the legal side of this, and I too have been following Dorit and Ross and some other folks on this. But from the ethics point of view, a couple of points. First, the religious exemptions mainly are not sincere. They are just roads out. And they're not people claiming that they have some deeply held religious view that leads them to not vaccinate. That would be hard to do since almost no religion opposes vaccination. In fact, almost all religions I'm familiar with, including Christian Scientists, who make it a matter of conscience, having talked recently to their church, to leave it up to you, encourage vaccination. So morally, it doesn't mean we have to celebrate people who are chasing exemptions under the rubric of religion. And a spurt of sudden religiosity indicates to me that that is less than sincere and ought to be identified as such. There are people who invoke things like the fetal tissue claim with vaccines. They would have to give up modern medicine in order to be consistent. And I think they should be asked about that morally. I'm not getting into what Seema can tell us what they can do legally. Third, and let's not forget this, we have states that have mandated vaccines for kids for about 40 years. And in the past 3 years, I've been involved in fights in those states, and 4 of them removed religious exemptions, removed them. California, New York, Maine, and Connecticut. Legislatures voted to take them out. They did so arguing that the importance of public health and the health of kids would override parental religious objection, sincere or not, demonstrated or not, authentic or not. And so I'm not totally convinced that you can't legislate in this area to put on, I'll end with this, some requirements. Show me the sincerity of your belief, bring me in some kind of statement from an organized church or whatever in order to make a claim. I know courts hate trying to decide what's a sincere religious belief, but their hatred of it doesn't mean you couldn't get into it. And then take on the issue of whether you're putting too many people at risk to permit religious exemption. At many employers, including the place where I am, we don't accept religious objection. You don't have to do it, but you can't work there. I mean, a healthcare institution.
That's interesting. I think one of the challenges is that in California, where we stopped having the religious exemption, that was for vaccination for children going to school. Whereas with employer-based mandates, there are some other legal issues involved when you have an employer-based mandate. Do anybody other thoughts on that, or maybe we should? Matt,
I wanted to ask Seema a question because I was intrigued by the framing of sort of where might religious exemptions be disallowed. And if I heard you correctly, I might frame what you said as the following. They should not be allowed if you are in an environment where other people who might be vulnerable are required to interact with you. So police officers, EMS, doctors, other people in hospitals, right? You can't choose not to interact with the food service worker in the hospital. That's not a legitimate option. And as a consequence, that food service worker may have a sincere religious belief. What that means is they can't hold that job.
Yeah, absolutely. And I mean, I think that there's a lot of interesting discourse on this, in terms of, if you are not going to be able to, if you go to the hospital because you're sick, or, you go to school because there's no online option, there is an argument to be made that you should kind of feel safe that you're going to be there. So not even as extreme as like having an interaction with a police officer or an ambulance driver, there might be other situations where you make that kind of argument. And so there is some flexibility in the law in terms of when that has to be accommodated or not, the religious exemption. And if it's in terms of undue burden, if it's too expensive or not practical, and in those kinds of situations, it's probably not practical to have like an EMS worker that's going to be working from home, right? And so there's flexibility there in terms of whether we need to accept it. I will say that this court, in terms of the Supreme Court, has been generally very accommodating of religious interests, over other priorities. And so in terms of thinking about, if what beliefs that a person subjectively believes, even if it's not like a recognized religion or like actually kind of central to someone's belief, generally the court hasn't gone into that kind of inquiry. And whether that's reasonable or not, that doesn't go into it. There's a lot of academic critique about that and whether that should change. But the bottom line is, if these, we're already seeing these kinds of court cases come up through the court system, trial court and appellate court system. If it lands in the Supreme Court, I'm not like super convinced that this is something that is going to be, the Supreme Court is very, very, I guess, respects the religious liberty more than other values that maybe, you or I would think would be as important, if not more.
Art?
Just two other comments here. So again, I want to stress, I understand where the legal side goes, and I understand what the orientation of the Supreme Court might be. That doesn't let us off the hook from calling out people on ethical grounds about hypocrisy or insincerity, or for that matter, sincerity, if they have it. But there is a moral assessment to be made here that's separate from, I don't want to get all caught up in just the legal side. Shame is a very powerful force. Kevin might agree, I don't know, but it's got its it's got its opportunities, and I think ethicists should be thinking down both sides of the street. Someone comes up to me and says, yesterday I had a religious discovery that I'm anti-vaccine. I'm going to question that. That doesn't pass muster with me in the same way that somebody says, I've long felt concern about this fetal tissue issue, for example, or pork products in the vaccines. But that leads me to my other point. And Kevin, I think, did make this earlier. You could still educate, persuade. When we had people around our initial flu mandates, both in Pennsylvania and when I came up to NYU, we did try to put on educational programming. We did try to have meetings with religious leaders. We had meetings with Orthodox rabbis. We didn't just say you're fired. I mean, we did try to go into education and what the opinions might be. So, that there's room for that as well. There were people for religious reasons who thought that their organized religion opposed vaccines, and we had to explain that that wasn't true and let them understand that better.
So this actually raises a question about how religious exemptions should be defined, if they do exist, which many employer-based mandates do have. You've expressed some skepticism about many of those claims, given that almost all religious groups have come out, and all organized religions seem to be in favor of vaccination, as well as the fact that at least some of the grounds on which people have been claiming them, for example, worries about the involvement of fetal tissue, are only peripherally involved at best with the mRNA vaccines, and only in the same way that aspirin and ibuprofen, Claritin, almost every over-the-counter drug or prescription drug is also implicated in the same way. So, so how would you go about defining this and implementing a religious exemption to weed out cases where that's really not genuine? I hear this a lot from our HR people about practically how do we do this?
Yeah, I mean, I'll make two comments. One is a pattern of authentic, sustained belief, not something that happened yesterday when people said there's a mandate and you announce I have a religious objection. I'm looking for some sustained commitment to a particular point of view. I mean, again, ethically, I'm not trying to drag them in front of a court to do it. I'm just sort of saying, we're going to have a discussion about religious belief. Can they give me a belief that's consistent doctrinally with some rationale that vaccines violated the fetal tissue is an attempt to do that? Okay. But if you just say, I don't like vaccines, I'm not sure that's going to rise to the level of a, legitimate spiritual religious objection. And many people do just say, I don't like vaccines when you push them. That's as far as they get. It's what we used to call, people on the call will remember, philosophical objection, and that was allowed for kid vaccines in many states too. But again, it is possible to push around in dialogue to explore morally either the source of your belief or the sincerity, or what I'll call the authenticity. It reminds me a little bit of informed consent. It's like, do you really believe X? Is it a reflection of your authentic values, or is it just something panicky that you're seizing upon because you don't know what to do to avoid the thing?
Any
You
other
know-
thoughts?
So NPR was doing some a really kind of interesting take on this the other day, and there's these mega churches where they're passing out mimeograph religious exemption forms, but I think to the care piece, we have to come up with messages, and I would say this is really important. I mean, we still have this huge challenge in front of us, but I have a student from Botswana, and her parents, there's no vaccine yet in Botswana, but her parents get all the negative Facebook stuff. And so we are marketing to the world all these negative things very aggressively. Her parents are scared to death of the vaccine in Botswana because they read English language, media. So I think we have to learn how to, while we're doing the sticks, we got to get better at this communication piece. I mean, it'll help us with this, why is it that this megachurch can get 20,000 people to agree to adopt their strategy and we can't do anything to get those people to change their behavior? I in a couple of the conversations I had, I said to reporters, I said, you realize if you told a politician that there was a group in this neighborhood, a neighborhood in their district that they really had to convince in order to win the election, they would be incredibly creative with content and messaging for that group. And we're like tone deaf to that right now. So, I think we need to do both, and this mandate's not going to let us off the hook. I mean, if we're going to have to wait till the Supreme Court rules on the religious exemption because we have suit after suit and state after state, we're not going to get anyone vaccinated. So I think it really has to be, this is an important, really important stick, but it has to be in the context of some strategy to get us to wherever we want to get to.
Yeah, and there's so many, I mean, these religious exemptions, I agree, are, for the most part, from everything that we're reading and seeing, are not necessarily sincere. And, there's all these internet sites of like how to seek a religious exemption. And so I do think that if you are concerned and the goal is to get your workforce or your university or whatever, completely vaccinated, you have to consider, from if it's a different kind of context, like a university context, perhaps not having religious exemptions. And, we don't know what the court would say about that, but, for public universities, but for private, you definitely could do that. But then also for employers, just making a case where, okay, if you have to kind of write out why you have a religious objection, there's going to be at least some people that are not going to want to have, that form instead of just the form that you check off. The people are already kind of coaching anti-vaxxers that they should, mention only scripture and not mention COVID-19 and all those kinds of things. And so, I think this is a struggle, but, removing the religious exemptions by either saying that this is just an undue burden might be the way to go. And then kind of, as you're saying, it's going to take a while before courts are going to consider this. And so if this is an important value for the organization, that might be what they would consider. And so, I mean, that's a kind of a circular answer, but if you are going to mandate, perhaps not having those kinds of exemptions accommodated might be your answer to get your goal of getting a safe environment.
Hey, Seema, I've got a question for you before we completely give up on trying to test the sincerity of religious belief. I mean, we did do this through conscientious objection through many wars, drafting to service, boards that had to assess, somebody's claim that they had a moral inability to participate in war, blah, 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 blah. Any precedent there?
Yeah, are you, so I'm on a listserv that was actually talking about this morning about the difference between the cases with conscientious objectors versus, when we're talking about religious exemptions in other contexts. And, I'm not sure in terms of, whether that line of reasoning in terms of for conscientious objections, if that would be the same kind of rules that would apply. I mean, that's definitely a parallel in terms of seeing whether, it is sincere beliefs, but I'm not sure they would be considered the same in an employment context as they would when you're, trying to enter civil service or not. But this is definitely a very, I guess, hot issue, because I just read a whole discourse about this this morning. And this is not, I'm not familiar with the conscientious objector types cases, but I mean, at least it definitely makes sense that there is a parallel there. I just don't know if that would be recognized. But I think, we can think about that as a as perhaps a way forward.
Yeah, but I guess if you think about the regions where vaccination rates are really low, the people who would serve on that panel are the people that are not vaccinated. So, I don't know how far that would get you.
So,
We'll just say,
sorry, go ahead, Matt.
just quickly, just having a mandate with no teeth whatsoever changes people's behavior. And we've got lots and lots of evidence of that over many years. So I'm not a fan of mandates with no teeth or mandates with, wide open exceptions. I don't think they're optimal. But I wouldn't say we shouldn't have a mandate because it won't be perfect, or because some people will be able to game it, or because it'll be relatively easy for people to get exceptions. A fair number of people will rather just get the vaccine, after all, than fighting these battles.
But the other thing about the idea of an employer mandate is that in theory, at least, something about your employee base, right? You're communicating with them, what their jobs are, and at least your message, there's a chance your message is going to be more tailored.
Right.
So, how do, that's at least one of these strategies to get more focused communication that might be more, get more traction. And obviously, if your manager comes in and starts chatting with you, compared to what you see on television, that might influence your behavior as well.
Two other quick points on Matt's point. Sorry to be pounding this into the grave. On the flu mandates, what happened was a lot of protests, people taking religious exemptions, blah, 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 blah. By year 3, condition of employment, everybody understood it, no noise, nothing.
Yeah.
People just do it. There's also the idea of mandating to the new employees. They expect it coming in. You don't hire unless they go along. You don't always have to rely on the federal OSHA mandate. You could be mandating under the power of your employment and just say, here's the terms, and either extend it only to the new folks or to the other folks. So I agree with Matt. You don't have to necessarily have the perfect federal policy. We didn't have one for flu. Workers in healthcare settings, very high rates as the mandates moved in. Sadly, if COVID is with us for a while, we'll get to test my multi-year hypothesis.
So I want to turn to one thing that was discussed by a number of people in the chat group, which is whether or not it makes sense to require mandates or have an exemption for people who have already had COVID, since there is at least some evidence that people who have recovered from COVID have an amount of immunity that seems to be in the ballpark of the same amount of immunity conferred by immunization. So should that be another area of exemption if you can demonstrate through an antibody titer, or because you've previously tested positive that you don't need to be vaccinated, to be exempted if you've already had COVID?
This is one I don't really understand. So why do you care? So the science seems to be, first off, there's not a perfect measure of immunity after some period of time, right? In the short term, you get IgM, IgG, then IgG kind of fades away and you have memory cells, and then those might work, might not work. So our ability to actually say, well, you really are safe for this period of time, isn't that great? And it looks like that, and especially if you had an asymptomatic infection, how big of an immune response did you get? So scientifically, there's some uncertainty, about how protected you are, but I don't get this. It's not like there's extra risk if you've already had COVID, if you get the COVID vaccine. So what is it? Why do you care? I had flu and I still get the flu shot. I had chicken pox. I just got my varicella shot. We do this all the time. And so this one, to me, I scratch my head on.
So
Yeah,
the
and I
fact
think,
that, sorry, go ahead.
oh, sorry. I think it would also create some perverse incentives in terms of exempting this, of perhaps exposing yourself on purpose to COVID. And I think there's too many unknowns scientifically about it to have this as a category. So I'm not sure also why this has come up over and over again.
Okay. So let's shift to the broader mandate issue beyond healthcare workers. Biden, as we've mentioned already several times, is planning to use OSHA to create a requirement for mandating vaccines for employees, any employer who has over 100 workers. This would cover roughly 2/3 of the U.S. workforce. Our vaccination mandates for non-healthcare workers who don't have quite the same duties and obligations towards people that healthcare workers do, also a good idea. Let's start with Matt.
Well, I guess I'll go back to what Seema talked about earlier, and I affirmed, which is there are plenty of jobs where other people don't have a choice but to interact with you. And there are plenty of job environments where the great majority of people there would rather be operating in an environment where everyone else is vaccinated. So I think if it's just a matter of, how do we create a safe work environment for as many people as possible, there's a pretty strong argument. And then, of course, there's the broader argument of achieving community levels of immunity to actually bring this pandemic to a close, which will require, with Delta's R naught numbers, probably 90% vaccination coverage. So very high levels of either vaccination coverage or prior infection. And, at the rate we're going right now, we might get there with prior infection before we get there with vaccination, but that should not just happen without us trying everything we can to achieve it via vaccination.
Go back a year ago, and the whole idea of building the vaccine in warp speed in the first place was actually an economic one. Remember, this is how we're going to get the economy open. This is how we're going to get businesses to be able to be stable and make investments, people back to work. And we're not talking that language right now. And I think that's really important. So the idea of focusing on employers and telling employers, look, it's been so chaotic over the last year. How do you do your strategic planning, not knowing where your workforce is, whether you need your buildings or not, whether or not, the bank next to you is actually going to bring the people back so you can open up your restaurant, for a small business. This is a huge, we've spent $5 trillion propping up the economy to try and get through this. So, the idea that we're going through employers to help them stabilize the business environment through vaccination is a message that's not being brought forward now, but that was the message we started with.
Incidentally, this gets back to the point I made earlier about the local health departments who really need the cover of a statewide mask mandate in order to implement the mask mandate in their own schools or in their own districts. The same is true for many small businesses. They need, and if you talk to them privately, they will say, we need this to be, broad. It can't just be me deciding for my own business, because number one, I'll lose a bunch of employees who, with absent a broad mandate, they'll just leave and go work down the street. As Art said, once we saw broad spread mandates in healthcare for flu vaccination, no one leaves because of flu vaccine, because they can't go work somewhere else. So, they leave for other reasons, but not over this. It just became a non-issue.
David, one other driver in the mandate business side is international requirements. So a lot of countries for doing business with them are going to want proof of vaccination to come in, Salesforce, employees going back and forth. And it's not small. I wouldn't say every small business is impacted, but a lot of the big ones that I talk to, they're moving to vaccinate because they got to move people around the world, and they're being told they're not coming unless you're vaccinated.
So we've addressed a lot of the questions that the audience has raised already, but I've got one that's focused on directed to Kevin. Do we understand at whom mistrust is targeted for the different groups you talked about? What might a strategy to address different targets of mistrust entail?
Yeah, so we actually came up with 12 different strategies. Again, if you had 2 years to prepare for this campaign, we came up with these 12 different strategies. A lot, some of it is identity. So we talk about identity politics all right now, and vaccines got rolled up into that. But there are other ways in which we could use identity to shape these messages. Like we piloted something with NASCAR, where we used entirely different language than we're using right now to try and appeal to that population, to see if we can get, and it worked. So again, how do we get identity that you're getting a vaccine to protect yourself, to protect your community, instead of, freedom, protections and community is another, or other terms that people use. So I think we want to take a careful look at identity and see how we dissect identity from where it is right now. But we came up with a list of 12 different strategies that you could follow, or I should say that we should be testing. I mean, again, this is the best we have right now. Some of these are going to work, some of these not going to work, some of these are going to work in certain populations, some not. And then I will say we followed that up. The World Bank asked us to follow that up, looking at World Bank regions. And we did a survey of 92 different marketing faculty from around the world, and then have got additional insights that's going to come out very shortly in the British Medical Journal of Global Health. But it was funny because what they did was most people around the world laughed at us that our approach to all this is so American. And that we really, as this goes out, things like nudges that we talk a lot about in the United States don't generalize very well, it turns out. But
Interesting.
But I think it's, we're still not too late to be testing messages. Again, the politicians do this all the time. We have all this technology to test messages, A/B testing. We just can't put all our focus on the mandate and how to implement the mandate and ignore the rest of this. We plateaued in May in terms of 52% of the population, and we're still there. There's 48% of the population we're not reaching. We gotta do a better job on that. And again, this downstream effects about what's going to happen in Nigeria when they try and roll out the vaccine.
So we don't have much time, so I'll end with one question from a comment from one of the reviewers, whether or not, in the absence of any kind of universal requirement for healthcare workers across the country, whether or not the Joint Commission could require mandates to make compliance non-optional, for at least for all Joint Commission approved healthcare institutions.
Oh yeah, definitely. It's been the driver on flu. And they absolutely could do it. And I suspect they might do it. One other comment, let's not forget that the impact of mandates also is accelerated by their taking place. And what I mean by that is if you vaccinate the military, the National Guard, and their contractors, it's a big slab of people who come home and aren't dead and maybe get some protection. And so you start to see messaging into the society because people seem to be healthier and they don't get sick. And so mandates have a kind of a cumulative effect, I think, as pretty large segments of the population move forward. That military mandate going into the National Guard and contractors is not small. And that gets borderline compulsory vaccination. The choice becomes which arm.
Any other thoughts about this idea of using Joint Commission?
Well, just that there's overlap, obviously, because OSHA covers hospitals as well. So the OSHA rules will apply to hospitals whether or not the Joint Commission chooses to pursue this. But I think Art's right. I think the Joint Commission will pursue this. There's a way in which the Joint Commission is a self-regulatory mechanism within the medical system, which OSHA is not. OSHA is an external regulator, and there's value to implementing this as a self-regulatory paradigm even if it's on top of an emergency temporary standard, which remember the ETS is temporary. So whatever OSHA does under an emergency temporary standard won't last forever.
David, I think it goes to the leadership issue too. I mean, why is the
Yes.
healthcare profession not out in front?
Hear, hear.
And there might be a difference in exceptions, right? Because the OSHA rules that are being implemented have pretty big opt-outs in place, as I understand it, for testing as an alternative. And Joint Commission might have more restrictive requirements for healthcare employers. So that's something else to think about. Okay, we're now at time. I want to thank all of our panelists for a wonderful discussion and thank the audience. There will be a recording of this that will be up on our website for anybody who wants to look at this again later. So thank you all very, very much. Matt, you had want to send us out on a comment?
No, I didn't. I touched that button accidentally.
Okay. Well, so I was going to give you the
That was
last
me
word.
clapping.
Okay, as you clapping. Okay. Well, thank you. I'm clapping all of you. Thank you all very, very much.
Thanks, Ed.